So, hi, my name is Lynn Roppolo. I'm from UT Southwestern. I work clinically mainly at Parkland Hospital, which is a large county hospital. And I became involved in this group because we were having a lot of physical assaults in the emergency department. And so just excited to be part of this group, which we've been working together for, I don't know, at least a couple of years. And so we know you're probably experiencing some of the same things we're experiencing. We'd love to hear your stories and kind of share with you what has changed our practices in the management of these kind of patients.
That's perfect. Great.
I'm David Lauterbach. I'm a resident at Hennepin County Medical Center.
At where? Sorry, I missed that.
Hennepin.
Hennepin.
Hi, I'm Susan Stern. I'm faculty at the University of Washington.
I'm Mike Vrablik. I'm faculty also at University of Washington.
Carl Hiskin, faculty at University of Florida, and I'm a nocturnist. So there you go.
I'm Hayden. I'm also a resident from Hennepin.
I'm Jamie. I'm a research coordinator from Hennepin. I'm Paige. I'm the other research coordinator from Hennepin.
I'm sensing a theme. I'm not from Hennepin then. Hey there. I'm John Casey. I'm the Associate Program Director at Ohio Health Doctors Hospital. And I'm part of this amazing team here. I got really interested in this due to some events in our facilities and some experience I had with EMS. So I have a pretty solid background in that, and that's what I spend most of the time with. And thanks to Ambrose and the team, I bring the pre-hospital into the hospital transition flair to the program.
Lauren Klein, faculty at Hennepin.
John Cole, faculty at Hennepin.
You guys make it sound like it's so bad.
I think if you're from Hennepin, you have to talk really quiet, so I think that's it. Hi, I'm Marie Vrablik. I'm from the University of Washington and have been enjoying working with this group on best practices around workplace violence, and I'm sort of focused on, in the department, violence, staff safety, severely agitated patients, and how to safely care for them. And thanks so much, and we're looking forward to talking with you all about that.
Hi, I'm Mike Wilson. I'm actually from the University of Arkansas in the Clinician Scientist program. I think Dr. Stern actually interviewed me for residency, I think, back in the day. So that is almost, I don't think I've seen her since then, so welcome. Most of my recent work actually has not been on agitation. It's actually been on suicide and opioids, big other sort of acute mental health emergencies. The iCare 2E tool, for those of you who've seen that on the ACEP website, is ours. Happy to tell you more about that after. Today we're going to talk mostly about agitation, which was sort of my first love and how I got into this group to begin with.
And I'm Marc Martel. I'm faculty at Hennepin County in Minneapolis. Workplace safety, patient safety, agitation management has been an area of interest for a long time for me. Perhaps I'm slightly more simple than Dr. Wilson. I only have one love. I am also a nocturnist, and I think that this is extremely applicable to many of the patients that we see, both at a county institution but across the country at night. So this is a really important session, and it's been an honor working with these folks.
Thanks, Mark. And my name is Ambrose. I'm on faculty at Yale. I'm really excited to sort of facilitate this conversation. We're just doing first names and sort of where you're from, just to get to know each other because the session is small. Do you guys finishing up?
My name's Bray Nylers. I'm a second-year resident at UW.
My name is Daniel Schultes. I'm also a second-year resident. That's Will Cleek. He's also a second-year resident at the University of Washington.
Welcome. It's great. You guys just finished snowy games probably, right? You guys just finished snowy games? Yeah. Great. Thanks so much. Sorry. They're asking me to keep this on for recording purposes. So I'm just going to kind of go through some housekeeping stuff and basic logistics, and then it's going to be a lot of dialogue. And obviously there's a big representation from Hennepin and from UW, so I'm sure you guys all have your perspectives on sort of what you think about this as well. So we're going to make this case-based, which hopefully will make it a little bit more interactive. And the idea is that we sort of have different perspectives on what might be sort of the way that we would prefer to manage these types of instances. But I think the overall takeaway is that there are some best practices that we should be thinking about, and that there is literature out there, perhaps limited, but it is actually evidence-based, and that we're trying to practice more evidence-based medicine. So we're wrapping around 3 different cases, and I'll introduce them one-on-one, and 2 of our panelists will sort of lead us through the process. And by the way, we had some disclosures around some small grants we got that I'm just skipping over. So I apologize that the slides seem to be moving on their own, but the big takeaway on a couple of introductory slides is that I want to think a little bit about intersecting workplace violence in healthcare and agitation management, which has been their own separate silos, which is silly because I think it's one and true the same thing. So this was Dr. Phillips from Beth Israel Deaconess in Boston who published this review paper in New England Journal, which shows that the healthcare sector has a significant increase in workplace violence compared to other private sectors, and a lot of media coverage on workplace violence, especially assaults on nurses. But the flip side is the way to manage these severely agitated patients or patients with agitated delirium, unfortunately, may involve physical restraints or sedatives. And the way we think about it is that we all sort of have our own practices at our own shops, but it's sometimes disheartening to have to do that. So a couple of things, which is agitation is potentially very high and critical when they're there. We have to take care of a lot of other patients. Some nurses have told me anecdotally that they don't see these patients as real patients. I'm sure you guys have maybe heard of that before as well. And that there's sort of lack of standardization. I want to point out Mike Wilson and their work with Project Beta through the AAEP that's done some really good work published in the Western Journal of Emergency Medicine back in 2012. Is that correct, Mike? And there was a series of 5 papers that did some really good consensus work, and there's a good reference that I look to all the time. So hopefully that's a good segue into the first case. So I'm going to ask the two of you guys to help me lead through this case. And this is sort of the interface when EMS brings a patient to us in the ambulance or in the ED, and some of the issues that might arise. Can I ask you to read the case and then get us started?
Maybe. Is it working? I can't even tell. Oh, okay. Wow. I'm louder in my head than I thought I was. So 45-year-old male in a park. Initial call was received for a subject not acting right. The EMS crew arrives in the ambulance bay with the patient verbally aggressive, yelling racial slurs and profanities at medics. So a totally unusual call, right? Like this would never happen. I'm going to look at it a little bit from the perspective of EMS, just to give that flavor, and my buddy Lynn is going to kind of help us bridge this intersection. One of the things, are there any EMS, particularly EMS physicians here that really are dedicated? Okay, good. So sorry, but I'm going to share some stuff that may seem kind of basic, but really, in the key takeaway that I want you to remember for EMS is that just as we have a paucity of evidence-based best practices and evidence-based training in the emergency room setting, we have that exact same thing in EMS. So an EMT basic, right, there are two, let's just break it down very basic, 2 basic levels of pre-hospital medicine with a tweener. There's the EMT basic and the paramedic, right? The basic has very fundamental skills, really, no IV access, no intubation, stuff like that. Basic airway skills, bagging, delivering babies, controlling bleeding, basic things, right? And then the advanced level providers have various degrees of training, including starting IVs and giving medicines and things like that. The EMT basics training is 110 hours plus 10 clinical hours, right? So how many hours of that do you think are spent on behavioral emergencies? And of that, what subset can realistically be spent on this type of patient, this agitated, non-compliant, we don't know what's really going on? So first of all, they are superheroes, but don't expect them to be superheroes, right? There's only so much training they have. And so the takeaway is that there's limited resources that these guys have to begin with. And it basically breaks down to their experience, the knowledge base that they have of having dealt with these patients before, and the tools that we have armed them with as medical directors. So for this particular patient, it depends a lot on where this happens, right? If this happens in the middle of Chicago, this is a Chicago call, you can have law enforcement there usually fairly rapidly. You're probably going to have an advanced life support crew, and your hospital is probably going to be just a few minutes away, right? So this is a person that, when they get there and they're not acting right, the EMS crew first has to deal with their safety. A lot of times law enforcement isn't there to begin with initially, and so they have to call them, and they have to manage that patient until then. They usually learn kind of on the job, unfortunately, how to deal with these patients. And, you know, there's everything from the, you know, we're not going to really take this kind of guff mentality to the, hey, we don't know what's going on yet. Let's approach this patient as a potential medical patient and work our way from there. Safety is the number one thing we teach them. So how you would even approach this patient, would you even get near this patient before law enforcement got there? And then once you've made contact, that challenge we have that we often face in the ED as the physician, is this a medical emergency masquerading, or is this a psychiatric emergency that is going to respond better to different things than maybe we would use, and maybe we would use additional techniques. You know, I think the way we approach our patients would certainly look different if they came in with like a hang tag around the neck, I'm secretly medical, and you would go digging for that, right? And if, truly, I'm just schizophrenic, and you would go, okay, let's spend a little more time talking. We don't really need to pin them down and get a head CT, right? So it would change the way that we would approach these things. And the EMS crews don't even have that. So once the patient is agitated, if talking and de-escalation techniques don't work, there's really two things left from their perspective. It's Brutocane, which is just force, right? You overpower them, and that's one method. And then the other is medication and restraint through whatever type of protocols you may have developed. It could be anything from Ativan to ketamine to MSEd to any of a whole host of other things that I've seen used as sedating agents, which I generally would not classify as sedating agents. Protocols vary widely across the country, and so it's very important that you're familiar with your EMS crew and what their resources are. And keep in mind that what they administer the patient, whether it's Brutocane, another drug, or just simple verbal de-escalation, can really have a huge impact on how that patient now presents to your emergency department, right? If they're telling you this is a person that was cussing, spitting, foaming at the mouth, and they've given them a whole bunch of sedating drugs, and they get there, lolly oxen-free, looking real happy, you can make a critical error in underjudging how aggressive that patient might be, and you might mistriage them to either the wrong category of care or to the wrong part of your department for safety purposes. You might skip some routine steps that you would normally do, like wanding a patient or having your law enforcement or your nursing personnel remove all their clothes and items because they just look a little bit more calm now. Well, of course they're calm. They've had a bunch of pre-hospital medication. And the last thing that I just want to touch on briefly is there's a lot of confusion about this, mostly because it varies a lot by state and by region, but you really do need to know if your pre-hospital providers have the ability to actually detain psychiatric patients. And by psychiatric, I mean the pure, they're just a little bit left of center when they get there, right? So maybe it's a schizophrenic episode that is presenting. The person, maybe they're not being violent, but they're not exactly acting right, and the pre-hospital providers have a concern about their care, but in some places, EMS providers aren't allowed to issue whatever variant you have, emergency confinement orders, temporary detention orders. They're not allowed to do that. And in some regions, they can do that. And so the problem with those types of policies is it may require involvement of law enforcement in what would otherwise be a simple case, because unfortunately when patients see law enforcement, it's now a different level, right? It's now a different thing that they're dealing with. And so that can unfortunately cause escalation. In some cases that EMS would have been able to manage adequately, were they able to do those things. So those are just a couple of my thoughts on the patients. So Lynn, my EMS guys wheel in, they come in sweating, wiping off and saying, here's this guy, he was just cussing at us, and we gave him some medicine and now he's better. How does that impact you in the transition of care?
Oh, so first of all, I agree with everything that you're saying, and I just want to add or emphasize a couple of important points. And one of them is, safety is huge. If it is not a safe environment, we have no business being involved in that. And we're as far as medical people, we're healthcare providers, and we're trained to do healthcare things. And so I think in this day and age, you can't underestimate anybody, and that just looks to me like a big potential threat. And if somebody is, and we're always, so that's one thing, is the safety issues. And then the other big thing, we approach everybody with kind of like our algorithm of like our decision making. And one of them, I mean, is there a life-threatening issue here? To be able to walk, which is your like sixth vital sign, that takes some significant effort to be able to come up with some of those racial slurs that he comes up, and that requires a little bit of cerebral functioning. So for me, just looking at this guy is not a medical emergency. I'm going to, if you can get an ambulance somewhere, you can get a police officer there, and there's no urgency for me to do anything other than trying to de-escalate that guy from a distance. As far as what our initial intervention, if you give this guy a medication, so now back to what you're saying, that you were able to intervene and you gave something to this gentleman to sedate him or to calm him down and to make him a little bit more cooperative. That's one thing he might present to the emergency department, looking cooperative. But the fact that he has a history of being agitated should not be ignored, because we've seen these patients. If we ignore that potential, I mean, normal people, they don't yell and say those kind of things to, just other people. So there's some potential there for more escalation, more agitation, and being verbal assault, I think we underappreciate as being a huge risk factor for physical assault. And that's something that I think we just need to recognize. And my passion about this, the only reason why I'm really involved in this is to get to zero. I think we can get to zero physical assaults by patients and ED staff. And every assault I've seen in the emergency department can be, I think, can be preventable using the beta guidelines and the things well outlined with de-escalation, the appropriate use of pharmacotherapy and restraint when appropriate. But I think if you ended up, so on the other hand, like this guy comes in calm. That's one possible presentation. If this guy came in significantly agitated and our attempts to try to de-escalate them fail, and we're trying to restrain him, just keep in mind that the restraint, physical restraint, needs to go together with chemical restraint. And especially if somebody presenting de-escalates to a point where he's actually like severely agitated delirium. I don't want to, we have two more other cases. The last thing I want to leave you with is that there are major complications, not the fact that he could hurt himself or he can hurt other people, but there are medical consequences for letting him continue to be agitated, from physically restraining him and him continue to be agitated from him resisting that restraint. He becomes like hypermetabolic, he becomes more acidotic. I mean, we've seen that, and we've also seen people arrest by being physically restrained and not kind of monitoring them, treating them appropriately, giving them appropriate medication, and doing the medical things that we need to do.
Sorry. And this is, and I appreciate everything. The one thing I want to be clear on, and this is why it's so important to know your jurisdiction well, because it sounds like you clearly do for your jurisdiction. But a little twist for you. So in a lot of rural areas, right, where the presumption of you're able to get law enforcement there easily, that's a huge fallacy. So I have a jurisdiction, just to tell you, I have a rural jurisdiction where at night there are 16 employed EMS providers working under my medical license and 4 deputies over 333 square miles. So it is not uncommon. And one of the things there, people talk about law enforcement transporting with EMS and things like that. Getting a deputy to leave their car at the scene there when you're talking about a 45, 50, 60, 80-minute turnaround time is really, the best case scenario you can get is often that they will follow along behind them, right, which is still not ideal. That very same agency, I've had a patient when the EMS crew stopped at a stoplight, assaulted the provider and ran out the side door. And the deputy, I will just say, was not the most physically fit deputy, and was not able to exit his car and abscond the suspect in time. And it was a huge deal. So again, that's why these things, you have to really know your EMS agency and what they have to work with, because it can vary significantly.
Three quick. I was just going to make super quick points and then just try and engage the audience a little bit. One, I think it's super important that you recognize your agency, and I'm reminded just how lucky we are to live in an urban setting and have this support. But I think that our EMS folks really are very well trained to treat these folks as patients, because there can be conflicts with officers there, prisoner versus patient. And I think that they're exceptional at verbal de-escalation. This guy sounds like he was pretty agitated. Our protocols actually have a distinction between severe agitation and profound agitation, and meds, antipsychotics, and benzodiazepines versus IM ketamine or the like. Your system's going to be a little bit different. But I think that when these cases happen, Lynn's point, very important, understanding what happened pre-hospital, and the transfer of care is really critical in my mind. I don't like to hear third hand from the nurse or from the nursing assistant about what this guy was or what happened. I really like to hear right from the EMS providers. In fact, we've piloted an area in our emergency department where paramedics will bring the patients in, anyone who's agitated or receives sedation. They'll be seen in an area, kind of immediately evaluated by providers and nursing staff, security will be present, to transfer that care in a very formal process so that points aren't dropped. I don't know, how do folks have protocols that they use in their shops that are similar or different, or what's your experience? How do you like to get a patient from EMS that was either required verbal de-escalation or pharmacotherapy? Do you typically have security involved when these folks come in, when it sounds like it's a concern, or?
Let me just ask a show of hands, because I think, given that the folks in the audience are probably, a lot of us are on the same page. How many of you would attempt verbal de-escalation for this patient? So pretty much 100%. Okay, so we're sort of preaching to the choir on that. How many of you go ahead and give oral meds or have some process by giving oral meds for folks who are agitated enough to require verbal de-escalation? Ooh. Yeah, or have a formal. We actually have an order set that just came in, but it sounds like you would just offer it without it. So actually fewer. Okay. And I'm kind of curious, because we were just sort of talking about this right before we came in. What's there? You have this guy who's come in, he was agitated enough that the EMS providers were concerned, did some verbal de-escalation. I'm wondering, what's the holdup? Why would we not offer this person some oral meds? Yeah.
Well, I mean, I think we would offer things that could be situational. I mean, if this guy has a psych history or just was kind of somebody who I politically, just by my assessment of his history, it could be just, he could have had a bad day or something, but there might have been some situation between that that needed meds to be able to de-escalate and maintain. But frequently, I think there's some issues that we kind of engage with this person has the high potential to get more agitated again, which is what happens in most cases.
So, this brings up a great, and I'm sorry, Maria, I didn't mean to cut you up, but this brings up a great point about what is the difference between agitation and aggression, and we've been kind of hitting at this. This panel is actually on workplace violence i.e. workplace aggression, and what is really the difference between the garden variety agitation that we see and our nurses or us getting physically struck. We've already alluded to kind of one risk factor, right, which is agitation. Nobody, I believe, has studied that formally, but it seems intuitive that that's a fairly large risk factor. Anybody know any more?
Some of the residents, maybe?
Yeah,
Do
risk
you guys
factors
have any
from-
ideas about
yeah.
what risk factors might predispose them to be more physically violent than other types of patients?
Yeah. Prior violence is by far the largest risk factor that's been documented, at least in the community setting. Any? Yeah, so that kind of goes along with the idea of impulsivity, which is sort of hard to measure in an acute setting, but if you're sort of impulsive enough to do a lot of meth just because it's Saturday, right, you're probably impulsive enough to do a lot of other things that would mean that you would be violent towards healthcare staff. And I think it comes back to this question about, you know, the appropriate use of meds. I'll turn it over to sort of smarter folks on the panel in that regard. I'll just point out, we know from some work that we've done that the oral meds just don't have the same side effect profile as the injectable meds. So if you're holding off on meds because you're worried about oversedation or because you're worried about respiratory depression or QTC prolonging or whatever it is that we're worried about, the oral meds just don't seem to have that side effect profile. So if you can catch them after you verbally de-escalate them before they've ramped up again, you have a valuable opportunity to get some meds on board. Mark, did you want to?
You know what? I'm sorry to cut you guys off. I just want to move on to some of the other cases, and I think the psychopharmacology will come back. Okay. And I know there's a lot of psychopharmacology experts right here, so happy to get to that. But I think that's actually a good segue into the second case that Maria, if you wouldn't mind leading us to, in regards more to workplace violence and assault on our providers. So Maria, you don't have to read the whole case in detail, but if you wouldn't mind summarizing and then giving some of your thoughts.
Okay, so 40-year-old male patient comes in with a scalp laceration, wants to leave, still has their IV in. The nurse has a different priority in that the nurse wants the IV removed. Patient doesn't want to get the IV removed. The nurse starts raising their voice. The patient becomes agitated, is pacing in the care area. The security officers are kind of noticing, kind of coming over. So what's happening? We can feel that tension building, right? So we've all seen this. This happens to all of us in all of our departments all the time. You come around the corner and you walk into this sort of like loaded gun situation. And you're physically confronted with this, and you're also sort of right thrown in the middle from a mental standpoint. What do you do? And I'd really like to hear some thoughts from anybody, because I know you've been there. I've been there.
How many of you give meds through the IV, then pull it?
But we're not even to that part yet. So what are you going to do?
I mean, I think there's a lot of variation in what I would do in this case. If this is a guy that I've seen for a while and that just suddenly ramped up and like, I just want to get him out of the department, I'd try and talk him down to a point that we can just get the IV out and get him out.
He does still have the scalp laceration. This is something to think about.
I mean, if he is agitated and is able to express to me that he understands that, like, if I'm able to realize that he has capacity at this point, like, just because he's agitated doesn't mean that he doesn't have capacity.
Certainly, that could be a potential, right?
So it completely depends on the patient as to where I'm going to be going with this. Whether I'm going to be saying, you know what, we're going to give you some IV sedating medication, or we're going to just pull the IV and get you out of here.
So seeing if you can reconcile your care plan to a safe care plan that's more in line with the patient's goals is something you would try to do if possible from a medical standpoint. I totally agree. Let's consider, and Ambrose and I sort of put this scalp lock in there on the head to direct us down the path. to remove herself from that area. Is that right?
Yeah, and it sounds like that's where this is going. I don't see the shades of gray in the real situation, but
I think that's something we should talk maybe a little more about, and I think it's really personally and from a research standpoint important to me is the provider safety and really all the healthcare worker safety, not just the physicians but the nurses, and then it begins to bleed over to the security staff safety too. Sometimes, all of the time actually, we are never going to be the person when things escalate and become physical who should be, in my opinion, doing the restraining or the physical stopping of the patient. It's not our job. We're not trained to do that. And in fact, I've talked to many security officers who feel that situations have escalated, become worse, become more dangerous, led to more injuries when untrained persons are attempting to assist with that. That certainly might be a point others want to discuss, but I would agree.
So I just want to throw in that, I think I work in a shop where I'm outnumbered by providers on a 5-to-1 ratio based on trainees being around me and these interactions happening. I ultimately feel like this is my responsibility. I don't ever want to get hurt. That's always a goal, but the patient safety is kind of a top priority. I always like to say this is where I like to come in with the most unexpected approach that a patient could anticipate. I just walk up and say, hey, I'm Dr. Martel, how can I help? And more times than not, people are so taken aback because people are telling them what to do or people are starting to crowd around them that sometimes you can just totally distract them. And that's often my valiant attempt at initiating verbal de-escalation. So.
I like that a lot, Mark. Just to add to what Marie said, I think, correct me if I'm wrong, what we're getting at is that simultaneously as a provider, as a resident, as a physician, we are balancing the safety of the patient and all of our safety, including you as a physician, but also the nurse and the security. And I think that is difficult. The added to that problem is that these patients are quite unpredictable. And of course, there's some individuals that you actually get to know well because you come in quite a bit and you know the roles that you can out. But oftentimes we don't. I would say in this particular case, he's at least standing, so I think that there is a measurement of him being sort of medically a little bit more stable. But, I mean, if I would make the assumption about what's going on with this guy, he probably is intoxicated, in fact. That's probably if he's 40 years old. But it's entirely possible that his sodium is 1.5 or something else. So I think I would want to explore that a little bit more and probably wouldn't want it to be quite yet until I know that for sure or I know him well enough. But the problem is that right now there's a standoff between the nurse and the patient. And so I think what Mark is getting at is that you can sort of come in between that situation and take that loaded gun, so to speak, that we're seeing away by intervening and avoiding that standoff. I think that's something that's very valuable. Please.
I'd say 100% agree with that. And I like to, just kind of know that they're going to read a whole lot off of your body language at that point too. Because if it's like, that sort of thing, that's very different from you just kind of leaning up against the counter or something like that and saying, oh, really? Okay, hold on for just a second. So what's going on? And just kind of redirecting that whole chain of events there. But, yeah, this guy, he ain't going home, or not immediately. Not in this sort of case for all those reasons we just yada. And sometimes I find it very helpful to throw the man to the bus to say, I'm sorry, the state of Florida says that you've got a head injury, and either I have to scan you and do some blood work, or I have to sit on you. I have to let you stay here for 6 hours under my observation to make sure you don't deteriorate. Sorry, it's not you, it's not me, it's just the man won't let me do that. And a lot of times people will kind of fall into, oh, damn the man, gets me too.
And I just want to thank you guys, and I understand that people have different opinions on this. I want to point out that based on some research I've done in this area, I do find that this follows gender lines, fascinatingly, maybe not so much, and sort of maybe I haven't looked at body habitus of providers. I mean, maybe when you're tall and bigger, you feel differently about this, but I do see this happening, different opinions on this, which I kind of find shocking, but then it's out there. And I also want to remind the attendings here that not only should we be thinking about what our gold standard for our own practices, but people are learning by watching us. So then are we teaching, is this what we're putting on our residents? This is my job, I should be there, I should get in there. Do you want your resident getting in there? When are they old enough to get in there? Is it when they're a third year, a fourth year? I mean, when is it safe for anyone? If it's safe for you, when does it become safe for your trainees?
For me personally, I'm very aware of space from the other person, and I'm also very aware of, where my arms are relative to how they can swing at me. So I'm not thinking about those things, but I might be kind of leaning up against something a little bit more, but having some interpersonal distance, so they can see that I'm kind of relaxed. And a lot of times they'll just feed right off of that.
I agree. I think body position is important.
Yes, I do actually help tackle them though too. So I'm guilty as charged. I would never put that on any of my
I know.
residents. But
they are watching. They're watching everything you do.
If there's like this many different security guards, I'll grab a leg or something like that. And then plus I'll get a lot of my security guards next time you say, come running, they know that I'm willing to dive in. And they also know that when I tell them to take their knee off that patient's back, that I mean it, and I know what I'm doing. And maybe I can prevent a little bit of asthmatic asphyxia or something like that.
You just got to recognize, though, very quickly, very keen to just go, when this is not going in the right direction. Like, I've seen Dr. Martel do the high of Dr. Martel. I've also seen the Dr. Martel that didn't work right now. And you got to retreat.
Well,
quickly.
team planning support.
And that's where experience comes in. And I guess every patient doesn't get verbally de-escalated, but there's obviously there's a huge spectrum. So you just have to be really smart about where your personal threshold is. And when the situation is that you can't compel that on someone else, it's a very individual decision. And just to play just the other side of it, like if I end up having to give this individual partial sedation in order to get their medical evaluation, get their safety under control, like I will sleep out that because I know I did it and for my staff, so I don't keep myself out.
So the neat thing about this discussion, I'll just make a kind of a side note, is that this is the first time I've talked about agitation to an EM audience that I haven't been asked, yeah, that's great, but what is the one drug that I should be giving these folks? Right? No. I do not want to leave this because I think this is such a important. This actually lies at the heart of the Beta principles, and actually Scott Zeller, the architect of Beta, just walked in the back there. So Scott's a psychiatrist in California who put together this effort through the American Association of Emergency Psychiatry. And we know it's important. This audience knows it's important. Marie's research has shown it's important. Dr. Martel is saying it's important. And yet, I would say 95% of the phone med stuff I read about workplace violence it turns out to be a giant laundry list of medications.
And they just went through that right just now from USC. So what is the group that they do phone med all the time? They had a whole laundry list about medications, rapid control, which is important. We're all talking about that's really important.
Right. But the verbal de-escalation piece gets a paragraph, and just take take this back.
Framework, you need the algorithm, and patients are different. That same patient could be different.
Exactly right. Yeah.
Thank you. So I did mention this executive for the case, and I think some of the pitfalls around medication choices or not will come into play with this particular case. I know, Mark, you put this case together. I think you might summarize it, getting the discussion started. This is a gentleman who did very poorly after receiving a lot of medications.
This is the gentleman who did very poorly. I just want the group, because you can read faster than I can kind of summarize for you. How would you describe this patient? Okay, I heard high risk. Yeah, before. So describe the scenario. Anybody? So he's high risk. I mean, when you read down there, you see that he's acidemic. He's critically ill. Would anyone term this guy as excited delirium, maybe? Or kind of on that cusp? Severe agitation, if you like those terms, if you don't like those terms. I'm a believer in this clinical picture. This is a super high-risk guy, and I don't think anyone would debate that for the patient safety, you need to interact. I think My biggest concern with this is that it seems like the provider here may have gotten stuck into the theme of just one more, and I know I can kind of take care of this situation.
Mark, can I pose a question? As a resident would
You're the
have come to
boss.
me and asked and said, listen, I have this guy, the nurse is coming to me, we just gave him 5 and 2, right? We gave him 5 and 2, I held out 2 of Ativan, he was down for a little bit, the nurse is coming to me now, he's yelling and screaming again, he's spitting at the nurses, what do you do next? That's sort of like mid-early phase of this case. And so you're at a point where you can potentially make a difference, I think is what you're getting at. How would you sort of guide the sort of management of that particular moment?
So I think this is a case to actually really easily armchair quarterback and say, well, you should have intubated him after the 2nd dose or after the 3rd dose. I know, clinically speaking, that these are really challenging decisions that we make. I know that there are residents sitting in this room and, uh-oh, not a challenging decision? Doctor?
No, I'm sorry. I just wanted to rewind a little bit
Mhm.
because I was the provider. This is how I got in. This is where I read your article. So anyway, he was signed out to me. He was sitting there looking very calm and collected in a chair. And sorry, he was. The only reason why I wanted to bring this up is because this is one side of the spectrum of the same patient, and then what you're reading is kind of the other side of the spectrum of the same patient. And he was actually sitting calm, just waiting to see psych. I mean, just like sitting like this, waiting to see psych. And I was busy working in a busy emergency department, and the nurse came up to me and said, he's getting a little agitated, can I have some Ativan? So I did it. I didn't see the patient. If it was today, I would have seen the patient right away, and then came back an hour later, same thing. I gave him 2nd dose of Ativan. And then the 3rd time that this happened is where you see it now. So I just wanted to make that.
And I think we had a question.
Yeah.
Sorry.
I need some clarifying information on the case because there's some missing points of data that are critical. So, is there a suspicion of alcohol use or not? And then what are these 3 doses of Ativan? What's the dose and what's the route?
PO 2 milligrams.
Yeah, so 6 milligrams total of Ativan is a lot of Ativan, right? And then any suspicion of alcohol or no?
He was using meth, alcohol, but he was not acting intoxicated when I first inherited him. He was just,
Yeah, it's tough to tell, right? Because there's people who can, especially with amphetamine or you can mask some of the depressant effects of alcohol. It doesn't mean that they don't have an effect on your medulla once you don't go clinically intoxicated. And that's what we're really, really safe. So there's alcohol. 6 milligrams of Ativan is a whole lot of Ativan.
he was alert
Yeah.
and sitting there eating a sandwich. I mean, like when I first got there, he was not acting abnormally.
Does anybody worry about...
I like to benzospare as much as I can. But looking through the...
You're saying you like to avoid benzos if you're giving an antipsychotic?
No, so what I mean by that is there's at least some literature to suggest, right, that if you give an antipsychotic in the family, you can reduce the amount of benzodiazepines you give someone, that you can spare the amount of midazolam or having to control their behavior or safety. But you also have some, my favorite two are haloperidol and chlorperidol.
What was it? After how long was that?
Chlorperidol or haloperidol. Just because they have less anticholinergic effects and heat dissipation is a big deal in methamphetamine intoxication. So, but, you know, when you look at least our Hennepin data, when you get down to the people who need a 3rd round of sedation, that's exceedingly rare and exceedingly high risk for something incredible.
And that's what I was just going to point out. Cyclic agitation is always a real worry for me. And it's, residents will come to me.
If you're treating it with a drug, you've got a long half-life.
Right.
If you give the DAS and 2 hours later they're back where they were,
Right.
that's kind of what you would expect. But Ativan,
So I actually have an algorithm that I'll talk through with residents, and it doesn't really matter necessarily kind of the order of the drugs. I typically do antipsychotic followed by antipsychotic. They're longer acting drugs in general. And I worry when there's kind of breakthrough agitation, recalcitrant or escalating agitation. And this is a guy that, even though you inherited him calm, And he did require some doses. This ramped up, and this ramped up pretty quickly. I mean, these are all risks that we know we're taking when we're managing these patients. I still find that the harder decision is, where do you intervene? Where is the right time to say enough is enough? And I think it is. It's very patient dependent. It's very situationally dependent. It's challenging if it's pure mental health or whether there's a component of alcohol. Yes. Unfortunately, I don't feel like there's a middle line with these patients who kind of reverberate, if you will.
I have, a couple of points to follow on to Mark there. Just a couple really quick points. First, how many of you think that you see this kind of patient all the time? Okay, yes, there's a lot of hands here. It turns out, and I always hate to present the Hennepin data for them, but Miner and about 4 other people in this room published a paper in Annals last year looking at the prevalence of agitation. Thank you, that's my notes on that. They found out that, and we can talk about how they classified it, but about 0.6% of all of the ED patients were agitated and had these kind of delirious characteristics. We're talking about a very, very, very small subset, okay? Very small subset. And I just think we need to go back to Marie and Mark's point a few minutes ago that verbal de-escalation is the way to go, okay? But here we are in case 3. It's the 0.6% of people that this didn't work on. And now we're stuck. What do we do? And Mark has a really good point. When do you intervene? Do you put a tube in and put him in the ICU? I'd like to offer another kind of thought, not supported yet by any randomized control trials, but some really compelling case report data, and that is Precedex. And it seems to work pretty well for these kinds of folks who are methed out. Okay?
So Precedex is actually a common agent used in our ICU, and we've actually toyed with it in our ED. And to be, I have to outright say I kind of disagree, Dr. Wilson, just because we do have some folks in our we do have some folks in our group who have tried it in this population. And to be honest with you, I think that the success rate has been small. 0.6% of our population is actually a fairly significant number on an annual basis. And I do make these decisions, I would say, probably on an every other week basis. I'm a little bit more tolerant than what's up here. I don't want to suggest that I give 2 doses of meds and then I tube somebody and put them in the ICU. But I worry. I've seen enough of these cases go wrong where somebody's just more acidotic than I thought, or somebody is already aspirated, and then all of a sudden security gets involved and now they have a smashed face on top of their meth and schizophrenia. And I agree. So in much of my writing, I don't often talk a lot about verbal de-escalation. It's my first thought. This is a challenging case. Nope.
Yeah, thank you. Thank you for letting me make one other point, which I think was kind of missed, which I think was really accurate for you to question when to bring in an antipsychotic with this particular case, because they had an underlying psychiatric disorder to begin with. So it was probably a good idea to bring in an antipsychotic earlier. The question I would bring in is something that, having been lead author on both the USA and the international consensus best practice guidelines, is that we've been moving away from use of haloperidol for about 15 years now. And it's always disappointing to me to hear that people are still going to that. That would be like saying you're going to use Reserpine for blood pressure. It's a really old med. It's got terrible side effects. A Cochrane review in 2017 said use of it is pretty much unethical if you have alternatives. So it would be solo use, but that's still, it's basically the same concept, Mike. And Mike even did a great paper a few years ago saying, why are people still resorting to this? I think when you see these bad outcomes where you're getting these unresponsive apneic patients, or you're getting these dystonias, some things that you often don't see, but we see when you transfer the patient to psych, are usually due to these first-generation antipsychotics. So the only thing I would add to all this, because it's a terrific discussion, but maybe consider more of the second-generation antipsychotics, because they're much more benign, they're much better tolerated, side effect profile's much better, and all the head-to-heads have been showing they're just as effective, if not even better, than haloperidol or droperidol.
What I go to in this sort of case, because you don't have to worry about the QTC prolongation. It takes a little while longer to kick in, but it doesn't cause, you don't have to have them on, cardiac monitoring or anything like that. And, almost no side effects that I know about other than they just chill out. And then the benzos, if there's the case of alcohol, I just say, you've heard of Whitney Houston, right? So just watch out for mixing. If you think there's benzos on board, if you think there's alcohol on board, stay away from the benzos if at all possible. But you don't want to wind up with it. They're like, yeah, barbiturates would be worse, but yeah.
My shop is super anti-depressant, by the way. Well, I just, this is so great. We have another hour long session. I really appreciate your time. Thank you so much for and I do have a list of members with a lot of the votes of these speakers over here in the audience. And the slides are actually on the website, so if you're interested down. Thank you so much.